Ta-ta.
Welcome to the Pain Podcast.
Scientifique. Welcome.
Oh wow! Oh, it's like Today is a special session hosted jointly by both of us. So it's Tim Beams and Bart Van Buchem here, and today actually we are going to try something a little bit new. We're going to try and put some thoughts about how to implement particular models. So we're going to talk about predictive processing. We're going to explore an ecological inactive model and do this with reference to a condition. So we have picked fibromyalgia. And we've got a loose title today, haven't we? A sort of working title to just help us through this. That we've called When Everything Hurts, Fibromyalgia Prediction and the Problem of Doing More. So, what are your thoughts, Bart, before we get going, about what this has in store for us?
Before we are absolute experts after this session, apart from that, we have we have had a couple nice things we've done on fibromyalgia recently. So I would, for everyone as a premium member, you have access to some conversations we've had with Laura Rathbone and Bernhard Taxe when we were around in Oxford. There's also recently we've published like a sort of masterclass with all the nuts and bolts on fibromyalgia and treatment assessment. So I think that will be worthwhile. Hopefully you appreciate these little things we put together for you just to make it work in the clinic.
That's it. Yeah. Well, that's why we're doing it, isn't it? There's a clinical tool, isn't there? So just to help you to understand and work through and come up maybe with some ways of opening up some conversations and understanding the responses and things like that. So hopefully this will be helpful to go alongside.
Absolutely.
So, fibromyalgia. Well, it's a funny one, isn't it? I don't see that many, I have to say, people with a diagnosis. I have one person at the moment in my caseload who has fibromyalgia. There is a real challenge just thinking about her diagnosis. I mean, first of all, was getting a diagnosis because there was so much other underlying symptoms and changes. So she had quite widespread, unpredictable pains. She was, so she was doing some really good things to help herself, but the response of that was highly unpredictable as well. And sort of thinking about her trajectory over the last year, probably not surprising that medication hasn't been the sort of the cure or the given her the benefits that she would have hoped for, at least. And it's been, at points quite disabling, and quite unpredictably disabling as well.
I see a whole range. I see quite a bit. Also men, by the way, as I would consider that it probably it's been lots of stigma around this condition for sure, as it was over the years. Although you can see some shifts happening, I find it quite what I just wanted to mention is the shift where it's sort of the new mechanisms sort of shifted to a somewhat simplistic diagnosis again, whereas people have things like central sensitization syndrome. That's what
in the past.
Yeah, it is still hear it some.
Oh, do you? Yeah,
I do. Or it's been a rheumatology. Within rheumatology, you can see there's depending where you are. Work and who you work with, it may relate to this is a more rheumatic disease-ish with inflammatory inflammatory compounds, or at least an inflammatory condition in a wider sense, like the just help me here. The systemic inflammatory condition. That was what I was looking for. And there is this movement. Yeah, sorry for that. And this other quite recently, I came across a group who was promoting it as this is a trauma-induced condition, so you have to take care of your traumas. As you can see, it's quite a large difference in how these different models may have relevance for sure, because we do know there's some systemic inflammatory condition, but it may not lead, hopefully not lead just to prescribe NSAIDs. So I would hopefully we can explore a little bit more, because before we started this conversation, we think all the models that I just discussed do suck quite big because they're not helpful in what you do in the clinic. So we're going to explore some more novel models that may be more helpful
Yep.
for patients.
Yeah,
Hopefully,
yeah. We're going to try.
we're going to try it.
Yeah, and there's a couple of sort of things in our minds here, aren't there? I mean, one is the challenge here of having widespread pains without tissue damage or identifiable tissue damage. Another is that people aren't believed. It's something that is a struggle for someone to understand what that person might be experiencing. That sort of lived experience is a real challenge, and communicating that and being believed there, sadly, is still a problem. And then like traditional approaches, the response to traditional, whatever that might be, engaging in some graded exercise, for instance, that it can be problematic, can't it? So, there are challenges here.
Yep. Wow. Well, plenty to explore here.
So we're going to put like a predictive processing like little slant on this, aren't we? And come up with some ideas here relating to, first of all, the predictions. And an idea that we are thinking how we might understand predictive processing is that we put strong weighting. So we heavily weight the predictions relating to threat and effort. So a strong overly confident, overly weighty prediction. So that's one thing. And perhaps at the same time, lack of or underweighted predictions relating to safety. Safety and well-being, and whatever that might be. So there's a sort of overconfidence, and I don't mean that in that you are overconfident in that threat, like deliberately, but the way that your system has aligned itself is that is the unconscious way that you are issuing your predictions relating to you and your actions in your world.
Right. So this assumes, and I'm going to be the naive here, because I'm always struggling a little bit with the models, to be totally fair about it. As I'm not, I don't feel an expert at all in this area, although I found it amazingly cool and reading books about this, but still found it very challenging, which I think many people would. So because one of those things. So in what universe are we if we're talking about predictive models and weight and mass and safety? How should I model it in my view. Compare, for example, where we came from. It's like the pathophysiology, the brain regions, and maybe even safety and safety and danger. For example, let's say, oh, there's the amygdala virus because you're seeing something. So how does it relate to that, let's say, or more I would say anatomical models, or models that relate to the central nervous system, how we sort of have been modeling it before?
Yeah. As in, if we peeked into the brain, what might we expect to see happen?
Exactly. So something that happens in the brain.
Yeah. And then we're going, oh God, we're just in the brain, we're not in the person. But yeah, obviously things do happen in the brain, and we think from a predictive processing point of view, we hold different understanding of the world, which are referred to as hierarchical generative models. We hold this understanding of the world in different timescales and different frames of reference at different levels through the neuraxis. So you might have an understanding of the sense of touch to the skin held at a really distinct, sort of fairly highly localizable area within the brain, perhaps in the somatosensory cortex. But then you might have my understanding of me and my world, my interactions in my world relating to my family or work, and then we would have more highly distributed networks of activity in a number of different brain regions, including the body, but then including a number of different areas that allow us to make sense of what that might include. Yeah. Not sure not sure I've answered your question, but that could include, if threat was there, then it could include things like the amygdala. We used to think of that as a sort of fear center, didn't we? And the insular cortex and the cingulate cortex, areas that have become more familiar to people thinking of network analysis of the brain, and networks like the saliency network. So your sort of difference attuned networks in the brain that allow you to pick up difference in the world. And from a highly weighted threat, we would say what is likely to happen, I think, this is my making sense of it. What is likely to happen is then we would expect these areas to be highly active if there is even a slight difference to my prediction. So they're very interested in anything that's out of the norm.
Yeah, great. So I'm not sure if we're ready for if fibromyalgia would have been, I would say, we often call it that someone who have this hypersensitivity or this hypersensitized condition in the central nervous system, or this increased sensitivity or lower tolerance for nociception, but widespread. How would you convert that to the models we're talking about, the predictive brain and fibromyalgia? So how would you, for example, verbalize it?
Yeah. So if that's become the default, then you're setting up what you expect happens. In essence, if you expect a loud noise to come from your environment, from touch of the skin, from literal noise in the room or the world, what we see happen within the body is that you get ready for it. So you ready the body in order for you to receive that. So it's a sort of self-fueling prophecy in that respect. So you raise the excitability within the networks that will allow you to process information related to that stimulus. So yeah, so you sort of, there are what metaphors, I suppose, that we would typically use for these. I wonder whether something like your oversensitive car alarm might be a nice example of what we see is the set point of that alarm is raised, so you need less stimulus in order for you to fire off a response, to have some activity within the alarm system itself. It's sort of changed its default then, hasn't it? Have you got other ways, or having had that like little think about the relationship of our overactive or hypersensitive states? What sort of things would
Yeah.
you use?
Well, I'm sometimes, to be honest, I'm struggling with, because there's so many different meanings in terms of how we use or define, for example, prediction in. So when it comes to education or talking about this stuff with a patient about their experience, I'm very aware that they not not be helpful because it could be quite distressing, is what I've experienced. In all my enthusiasm to talk about, well, your brain actually is not just receiving information and make sense of it. It actually has a prediction.
Ah, yes,
And
yeah,
then it
yeah,
comes
yeah,
to
yeah.
pain, and then we go, oh my God. So why does it predict pain? Where's the good for it? Like, oh God, I can't. This is so you got on a different level. So there's a higher risk, I would say, of misunderstanding. Um, so if the prediction would have been pain and the body thinks that's the most sensible thing, and new information doesn't create any change, if you like, whatever you do, or it does enormously, it's probably because of an error of that doesn't exist, right? So it's basically expected.
Expected is,
It's
I think that's a
expected.
nice
And if
term.
it's
Anticipated or
it's
expected.
anticipated, and when it's something so what we should do in therapy is do something unexpected, or something perhaps creating, but we also have to create safety. So it's a challenge to find something unexpected safe. That will be but then the patient get these glassy eyes.
Yeah,
Like,
yeah,
whatever.
yeah, 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 yeah,
And
yeah.
some
Okay.
people are really into it. I once had a guy who was, he had a degree in I'm not sure it was neuroscience or mathematics, but he was really into this stuff. And he was at some point he was basically teaching me on all this. And he was starting to read more than I ever can read on this. You can see you can see the
So
interesting sessions that I've had with the
y-
guy. Yeah.
yeah, yeah, that's it. I mean, often we have patients and they are researched and understood, and it's great learning together actually in those instances, isn't it? Can I pick up on what you said, because the terms I typically use, I don't use prediction so much with my patients, but I often use anticipation. So, and in English, I think that works quite well. Or what do you expect? And you can use these, can't you? Because you could say, oh, what are you anticipating will happen if we get you to bend over and pick something up from the floor? Or what would you expect if I asked you to get on a bike and cycle gently for 5 minutes? And we could start to grasp what their levels of predictions are, their anticipations and expectations, and perhaps we could start modeling it with them by saying, how confident are you in that expectation? You know, if 100% was 100% confident, it's definitely going to happen, and naught is no confidence, it's very unlikely going to happen. You know, where would you lie on that scale? So, you know, we can have a go at mapping these out perhaps with people. And I know I've talked to you about this, but I have done this, and I famously did this with my father-in-law, where I said, you know, what's the chances of you doing the exercises that I prescribe for you? And he says, what are you saying? That I will or won't do them? I said, well, just humour me and let's come up. He's a mathematician anyway. He's got an analytical brain. I said, well, you know, 100 is a 100% chance that you're going to do them. Nor is you're definitely not going to do them. He says, well, it's somewhere around 2 or 3%, isn't it? It's so, and I think that's a really good, a good indicator of going, okay, so in that case, do we continue along this path, or do we need to change something?
Yeah, so that will be indicating low trust, if you like, or not. Or high precision in I'm not going to do it.
No, I'm not going to do these
So
exercises.
yeah,
Yeah,
and
yeah,
to
yeah,
the
yeah.
pain conditioners, if that will be if you're going to do whatever this exercise or this yoga or this breathing exercise, not necessarily by doing it, but their result, I'm going to be in pain after this.
Yeah, yeah.
Um,
And then, yeah. So we could use these. Why do it and then make them really awful? Why not ask them about it and figure out what those expectations are and how strong
yeah,
they are first, and then allow that to help guide what you do with them as well, including like what's the chances that we come up with an idea and you run with it at home. So I like this as a model. I know you want to jump in, but you mentioned something else that's worth bringing
I'm
in
just going to
here.
write it down. Just come back on that.
Sorry, but you said about maybe if the default is pain, I'm very confident that I'm going to be in pain if I do a 5-minute cycle or walk to the shops. Then as part of the therapeutic reasoning here using these models is we're trying to create some sort of violation in that expectation, which sounds horrible, but we're trying to create something that's different. But now this is the challenge here, because with a population like someone with fibromyalgia, is their system is so sensitized to something being different that different, albeit very tiny amount of difference, might be too different. And when it's too different, then things will, not literally blow up, but things will literally be set off and gone. Too much, I can't do this, and I think that would be very typical of this population, where we don't have much of a buffer, we don't have much tolerance here, so we need to find difference, but not too much difference, and that itself is a mega challenge. So perhaps with someone who's got low back pain and it's more of a mechanical presentation and it's relatively acute, we can look at fairly, strong expectation violations. But for a population with fibromyalgia, I think we really have to be very, very subtle and gentle and kind and with some of those violations. They're called prediction error minimization. We want to create prediction errors. So yeah. Sorry, coming back to what you were thinking.
Yeah, and it relates to this. So the way you present it right now, it feels like when you discuss it, it's a cognitive expectation. I think that it will happen, but is there, and I assuming, because that's what I was suggesting, probably it's not just the thought, it's also the bodily response, for example, or maybe there are many others like a endocrine response, the immune response, the emotional responses, whatever you want to. There may be overlap there, but if we just, do we just do these kind of talking therapeutic approaches just because we can't manage the other ones, or can we also sneak into the other responses?
Yeah, it's a good question actually, and worth having with your patients as well, because from again, if we're taking this predictive processing model, there's a idea around the interface that action and prediction happens, which is called your Markov blankets. Uh, so now I suppose it would be natural to assume that that is the skin, but that may not be the skin. It may be a number of different levels, and it may be much more dynamic than that. And therefore, the interfacing might be the interfacing of neuroendocrine system, as you just mentioned. It might be the interfacing of person and their world. Maybe there's that dynamic space-based processing that go on. It might be the person within their local but more global world as well, and those interfaces are highly variable and dependent on, again, coming back to those models, is understanding the way that we relate to and interact with our world. So we can interact in a very sort of local, precise way, and a more global and bigger, and over a longer time point as well. So yeah, is it purely cognitive? No. I think, and this ties in with what we think about, I suppose, a newer way of understanding education in pain, is that it's something that you have to do, something that you have to feel in order for you to be able to update some of those predictions as well. So yeah.
I like it. And what's the role of experiential learning, and specifically fibromyalgia, because that's where the challenge lies, particularly with fibromyalgia, when pain onset is typically with a delay. Could be 24 hours or even a bit longer in some cases, I think. Because that's what my patients complain about, or that they struggle with. I can do today, but I'm pretty sure I'll be dead tomorrow.
Yeah.
So,
Yeah, and I don't know. So like all of this is us trying to figure it out and use a model and make sense of it. And I was saying to you just before we came on about entropy, wasn't I? Entropy and uncertainty. So you have high entropy is high uncertainty, low entropy, low uncertainty. And perhaps here we've got high certainty of there being pain, of being the same, being, the same, and then we have something slightly different, is enough different that it fires off that uncertainty. It fires off an entropic sort of experience within the body. And I relate this to allostasis. Or this is the way that I'm conceptualizing it. So homeostasis, relative balance; allostasis, when there's challenge; allostatic load, when you stay in that sort of challenge for a long period of time; and then obviously you have allostatic overload. And I think, thinking about this population, I think what we have then is the difference attuned. You notice difference and uncertainty is a part of that difference. You're highly attuned to notice that there is difference there, or in a different state, it sets off this entropic state, a state of disorder and uncertainty and unpredictability, which is in essence what we see in terms of the presentation and the symptoms and the varying over time. So I think what probably happens in someone's body is that they're in a massively stressful situation very regularly, which is a brilliant way of just hammering home, the certainty of there being uncertainty, the certainty of not being able to engage predictably with exercise or lifestyle choices or the world, and increasing the strength, the confidence in the expectations and predictions, but increasing the activity, the sort of resting state of those different attuned systems as well, like your saliency system, for instance. Yeah, I was going to come back as well. Because you mentioned about the cognitive or the bodily, and from a predictive processing point of view, people do try and separate those out and talk about, taking action perceptually, changing perception versus changing action. And actually there is a school of thought which is that they're inseparable, which would fit beautifully with another model which is called the ecological inactive model, where you're saying your thoughts and understanding of the world relate to your actions in the world, and you're not separate from them. So yeah, I would say the cognitive is never separate from the bodily, and vice versa.
I like that. I can see the challenge, whereas we haven't been educated like that, right? So it's quite a big shift to think about a model that's not relate, because we have all these systems we've learned about. So does it make all these systems redundant? Not by itself, because they have a role, but from this model, you're not talking about, you don't separate these these systems, right? You're not talking about an immune system. It's a part of that's an apparatus that's basically the body consists all these things, including skin and brain and body and all the parts and bits and pieces of it, and all the way it interacts, which is sort of a bit challenging, because it's somewhat needs you as a clinician, if you're used to think from that. So it's your immune system that's overactive, for example, like that. That's a very common narrative I hear. That's pretty bit. It's a bit under pressure, right? So you can't from this school of thinking. It doesn't make sense. I don't think this is not going to be relevant. This is probably something. It may be a little bit of a be falsified in some way. I do think it's hard. So how far do you think this, or how does fibromyalgia relates to this model, and how it's been adapted in the research world? What have you seen so far in the last years? Is there been a shift of interest towards this model to get a better understanding of what fibromyalgia means and what it is and how it's
should have done a literature search beforehand just to be able to answer that question, because I don't know. I don't know. There is more weight and evidence being put into the predictive processing model and pain.
I did a
and
little search though, but you can see there is, but it's not very specific to fibromyalgia, but lots to chronic pain, by the way, and huge amounts on consciousness. Huge.
Yeah, exactly.
Yeah.
But I think what it does do is it gives us a little bit of a sort of better ability to be able to understand why even doing the things that might typically be considered healthy and promote well-being and be relatively safe, even if you're doing them well with someone, the chances are, if their system is in that heightened state of prediction and difference noting, then changing something to be something slightly different can in itself be a stressor, can be something that sets things off. And it's like the straw that broke the camel's back then. But it might be, instead of putting a straw on, it might be taking a straw off, might have been what did that. And you're like, well, hang on, how is that even possible when I'm trying to make things easier? But if we understand things from a difference point of view, then perhaps that allows us to come up with a better way of integrating rehabilitation here, where we're looking at building a baseline of safety, but probably building that very, very slowly. Very small differences, micro-variability, micro differences. So your time frames and time scales are going to be massively different for this population than another population. So yeah, that's what I'm taking on board anyway. Are we going to try our best to try and summarize where we've gone? I mean, it's a sort of hotch of us trying to figure out, whether or not predictive processing has a role to play in fibromyalgia. So we started off just saying fibromyalgia When Everything Hurts was the working title that we got, and fibromyalgia prediction and the problem of doing more. And you can see, I hope now, just with this conversation, where doing more isn't necessarily better, but nor is doing less, because they would be, both of those would be creating a difference in the experience and how that relates to the expectations of that experience as well. And we were saying that we think perhaps one way that their systems go is that they heavily weight the expectation of pain, fatigue, etc. And that means that they also underweight, or there's a lack of, or it's low precision in the confidence of there being safety or comfort or well-being, or feeling energized and energetic. And if we're promoting anything that makes a difference to their expectations, to those predictions, the way that their system is set up is that it's so highly attuned to notice when something is different, that in itself can be expensive on them, that uncertainty, the entropy that we talked about. The uncertainty may be linked to biological processes, including whatever happens in an allostatic state, of load and challenge. Like you said, maybe the nervous system, endocrine system, immune system, etc., is involved in this. And perhaps rehabilitation, part of it is not trying to change things too quickly, is trying to create stability. Very, very minor changes, very micro variability, so that they can get used to even tiny adjustments, tiny changes, over a period of time, and slowly update. Maybe it's like not even 1%, maybe it's 0.5% a week of adjusting some of those predictions. So that's what I think I've got from trying to figure things out together.
Yeah, and I learned a lot. No, I like it. It's sort of talking about these models and these concepts is quite important to me personally as a way of understanding this. I did read books like Andy Clark, Surfing Uncertainty, and there are heaps of great books about a better understanding of these complex. Well, they are mathematical concepts in a way.
Begin with.
Yeah, so you need a bit of you have to learn or understand these definitions as well, because they can be quite challenging. Otherwise, there's a lot online that would be able, and hopefully this conversation helps you to get a better understanding of it and get excited about it, because I do think we are moving into a new era of understanding consciousness, and how the body evolves and how our thinking and our health is evolving. And if we want to make a little bit of a difference, as a movement therapist in general, I can see lots of opportunities where we can find the right pace and understanding of how and what we are actually doing instead of just pushing. Which makes a lot of sense. If you work with fibromyalgia, you've learned to pace as a therapist a lot, and be very much aware about this is not just by doing less or more. It's you need a different model, because the other ones, as I said before, they're not helpful to guide or to navigate. And this gives me at least a feeling of that it probably does. Yeah.
Cool.
Lovely.
Awesome. Thanks very much. Well, if you've got any thoughts, comments, etc., how did you sort of reason things through, then please let us know. We'd love to hear. And looking.
Absolutely. Thank you for listening, and see you soon.
Cheers.
Cheers.